Okay, Jane, it's 12 o'clock.
Okay, welcome everyone. Welcome to this Community Matters workshop session, and I'm Jane Hartley. I'm the North East Regional Social Prescribing Facilitator. I'll be co-chairing the session along with Siân. Siân, do you want to introduce yourself?
Hello, yes, I'm Siân Brand. I'm also a member of the Social Prescribing Network Steering Group.
I'm just going to run you through what we're going to do today. We've only got an hour, so it really has to be quick. Siân has actually, just in case you've just joined, if we could ask everyone to put their microphone on mute unless you are actually speaking, and also to have your camera turned off, which may just help the whole bandwidth thing. Right, I'm just going to talk a bit about the format of the session. I'm going to talk about that first. So we're going to have the speakers have actually pre-recorded their presentation, so we're very shortly going to be running through the presentations one after another. We're not actually going to take questions until the end. There will be, if you could post questions in the chat, and we will address what questions we can during the Q&A at the end of all of the presentations. But if we don't get to it, or if the presenters can answer it in the chat, they will do, because we haven't got a lot of time. The presentations will be shared on screen, but if for some reason you're not able to follow them whilst they're being shared, so because of the device you're using or bandwidth or whatever, then you are able to download the link from the chat and watch them separately. Can I ask everyone to go on mute if you're not actually on mute?
Next session is starting, but I've muted it because they're just.
Can I ask you to go on mute? We can still hear someone.
Social prescribing. Yeah. Two whole.
You're on mute.
Jane, you're on mute.
Jane, you're on mute.
Okay, so how did I go on mute? I didn't press anything, but anyway.
Somebody turn their cameras off, Jane. Well, and apart from the person who's actually talking, because then we can see the speaker.
Yes, that's what I asked them to do. So
Yeah,
if everyone can turn their camera off and go on mute. I don't know how I went on mute, unless they're actually speaking or presenting. Okay. We still have people who have not on mute. If I could ask you to go on mute, that would be great. So we are going to do a quick poll in a minute to ask how well you think social prescribing is asset-based and community-focused in your area. And in order to actually vote in this poll, you need to go to menti.com on your device, on your phone, on your laptop, whatever it may be, and enter the code which we will put in the chat. So it's a bit like what happened earlier if you were in the main sessions. It's quite straightforward. You will then be able to see the question on screen and be able to vote. We'll just do that in a second, but if I could just kind of talk about what this session is trying to do. If you heard Andy Burnham's he just did his keynote speech, and that was great because it very much talked about the need for a robust and vibrant voluntary and community sector, and how valuable that is in communities in terms of the social prescribing agenda. There has been a lot of investment through the NHS in link workers, but as someone once made the correlation, there's no point in having lots of travel agents if there are no holidays at the end of it. And actually, this is about making sure that we do have an asset-based approach, a community development approach to working with our communities so that we build vibrant, sustainable and engaged communities that can actually support the social prescribing infrastructure. And we're going to talk about we're going to discuss in a minute or look at some really brilliant examples, very different examples that are really embedded in communities. Can we move to the poll now, Siân? So if you go into menti.com on your device, if you haven't already done it. And then Siân has shared. Are you sharing the code?
Jane, there's no way to score. There's no way to fill out the boxes on the Menti. It asks the question, but it doesn't give you an option to fill out which answer you want to give.
That is just the slide telling you to go to menti.com. So when you go to menti.com, you enter that code 3604401, and then you will be able to answer the question. So we've just put the question on screen and shown you the code to use. Is that clear?
I can't. I've got the question, but I haven't got a series of boxes for me to choose how I want to answer the question. Maybe I don't know whether anybody else has.
No, I've got the same issue, so there doesn't appear to be a box.
Hey Jane, let's leave that question and go on to the presentation, shall we?
Yeah, okay, right. Sorry about that. We might be able to resolve that at the end, but let's move into the presentations now, which, as I say, are pre-recorded. So the first presentation, which Siân is hopefully going to put on screen, but as I say, the links will be in the chat box if for some reason you can't see the shared screen. And this is a presentation by Bromley by Bow Centre in London. You will have heard reference to that in the keynote address at the beginning, but this is talking about social prescribing outcome measurement and measuring what matters to communities. And it's a presentation by Dan Hopewell and Catherine Godward, who are involved, have been involved in this piece of work. Off we go.
Hi, I'm Catherine Godward. Thank you to Jane Hartley and Siân Brand for introducing us, and to all organisers for the opportunity to share Bromley by Bow's work on social prescribing outcome measurement as part of this session on the future of social prescribing in communities. For Bromley by Bow, this means measuring what matters to communities. First, Dan Hopewell will now share the Bromley by Bow context within which this work sits.
Thank you, Catherine. As an introduction to our community-informed outcomes framework, which was developed with the support of Public Health England, the Health Foundation, the Wellcome Trust and OCS, I'd like to give you a little background about the Bromley by Bow Centre. The centre was established 35 years ago in London's East End as a community initiative to improve health and well-being and create opportunities for growth and development in one of the UK's areas of long-standing deprivation. Community agency and learning is the driver of our model and its development. Growing out of a dilapidated church in 1997, we expanded our buildings and scope to become the UK's first healthy living centre, creating an integrated and holistic programme of community health and well-being. Our model integrates an extensive programme of community development such as the arts, horticulture, learning, welfare advice, employability and social enterprise incubation with primary care and population health. Social prescribing has been a cornerstone of our model for over 20 years. This outcomes framework has been developed with our community to understand our impact, support learning and reflection, and inform further development of our model. Over to you, Catherine. Thank you.
There are three outcome levels or perspectives that are important to measure to understand outcomes from social prescribing, as set out in the Common Outcomes Framework: people, service and community groups. Bromley by Bow has developed and is implementing a community-informed outcomes framework at an individual client-patient level that accommodates all the people level outcomes listed here and more for the whole Bromley by Bow model, i.e. social prescribing and any Bromley by Bow activity that might be prescribed. And it's this that we're talking about today. The Bromley by Bow Outcomes Framework is a result of 2 years of consultation with members of the community to identify the ingredients of a good life from community members' perspectives, set within a current and historical context. Community in this case means residents, practitioners and staff. All responses have been collected into 6 outcomes: basic needs met, connection to others, connection to place and community, strengthen personal resources, built knowledge, skills and opportunity, contribution to the community. These outcomes are what matters to communities. The stretch element of each accommodates the possible range from a foundation to a growth level. So in the case of strengthened personal resources, after social prescribing, a client might feel more confident to cope. Equally, they may be trying new things to improve their health. Both are valid outcomes of social prescribing. To find out what change looks like and an approach that works, we've consulted with practitioners, the very experienced external advisory group this project works to, and crucially, the internal advisors across Bromley by Bow Centre and Health. The result is a tool made up of bespoke and validated indicators with 14 domains, 36 objective indicators asked at the close of social prescribing, and ONS4, a pre and post measure of wellbeing. Bromley by Bow codes presenting need to intended stretch outcome to monitor need against the outcomes framework. All data collection is administered by practitioners and service delivery colleagues. This diagram illustrates this works in practice. Focusing on data collection points, this diagram maps the client's linear journey from referral to last call, including take-up of activities included within a prescription. Bromley by Bow's approach measures change after an initial social prescribing conversation, at the close of an activity, and at the close of the final social prescribing conversation. Looking solely at social prescribing as a mechanism distinct from activity take-up, this is the information shared. When a client is first referred, Bromley by Bow staff record service need data using a bespoke tool. If that progresses into a full call, the link worker will use a bespoke tool, drawing on MyCore, ONS4 and bespoke indicators to measure service take-up, a wellbeing baseline, outcomes from the call and satisfaction. At the close of the known final social prescribing conversation, clients are to be asked about changes that have occurred that map to relevant stretch outcomes and wellbeing. Separately, the approach includes gathering similar service take-up and outcome data from clients that engage in Bromley by Bow's wide range of activities, as listed here, as part of the prescription. If you'd like to find out more or trial the Bromley by Bow outcomes framework and methodology, please do get in touch. Thank you. I'll now hand it back over to Jane Hartley and Siân Brand.
Thank you for that. That's great. And we do have Catherine and Dan in the room, and they will be able to answer questions in the chat. And if you want to post any questions for them, if you could make sure it's clear that it is for them, and they'll try to answer those questions either verbally in the Q&A or in the chat if there isn't time. Right, we're now going to move on to the next presentation, which is from Alison McGregor, who is the Director of Altogether Better, and we'll be talking about working alongside people in communities and the future of social prescribing. Thank you.
Good morning, everyone, and thank you to Siân and Jane. My name's Alison McGregor, and I'm the Director of Altogether Better, and I'm absolutely delighted to be joining you this morning to talk about how we built a sustainable, strong social prescribing service with people at the core, with people in communities at the core. So delighted to join you this morning. I guess there isn't anybody in this audience that would not recognise the major change that general practice is going through at the moment. No longer is it a place that is there only to treat and diagnose people. It's become a place that needs to respond to a new kind of need. It needs to meet the needs of people with long-term conditions, people who are struggling to cope and adapt and manage with the things that life throws at them. So it could be bereavement, unemployment, hardship, lack of hope, the things that people need other people for more often than not. We have seen a fantastic opportunity with the new PCNs in the way that the practice family has been able to extend in order to meet these needs. So we've seen social prescribing link workers, coaches, care coordinators, and an increased willingness to work with the voluntary sector. And although this is a fantastically great start, we don't think that it's enough in order to respond to the scale of the need that exists out there. Over the last 10 years, we have been working with general practice, and our data shows that between 40 and 55% of people who present to general practice present with a non-clinical social need, and 4% of the practices list take up 20% of its resource. So there is a real need for general practice to work differently in order to meet the needs of this group of people. And we think that collaborative practice, which is an evidence-based approach, is partly an answer to this challenge. When we look ahead at a sort of the post-COVID future, we see an increase in unemployment, an increase in poverty, in hardship, increase in mental health problems, mental illness. As people have returned to general practice, there will become more demand on general practice, along with increasing financial squeeze on public sector, on the voluntary sector. So we need to find a new way of doing things. But when we look through the sadness of the past year, what we also see is the incredible generosity, care, kindness and compassion that people in communities have had as they step forward to help their general practice, to help other people in their community. And this hasn't been a surprise to us in Altogether Better. We have worked over the last 10 years with 26,000 people, more than, who have come forward to give their time to make life better for other people in their community or in their practice. And we think that general practice is incredibly well placed to bring together their insights, their data, their understanding of the needs of the community. They're able to invite people who are on their list to step forward, to give their time as practice health champions, which we know they do incredibly generously. Those people, when they come together, we help them through collaborative practice to form a new extended social team who begin to work together to do things differently, to respond in a different way to meet the social needs. And what then happens is the general practice can then provide the right support to the right people from the right place. So sometimes people will need a clinical support, or they'll need a specialist trained worker, either from the voluntary sector or from within the practice. But many, many times, people just need other people. And that's the role that practice health champions can play in supporting general practice to respond better going forward. So there is lots and lots of evidence that we have amassed over the last 10 years about the evidence and the impact of working together with people in communities. We find that staff find the joy in work again. And if you go to our website, there's some fantastic resources, films of people talking about the impact it has on their day-to-day working life. We see improved recruitment of staff, better retention of staff, a reduction in sickness absence. We see that there's a huge increase in capacity within general practice to deliver. The first practice we worked has 60 practice health champions today who deliver more than 40 weekly activities. The plethora of new activities and the new offers available has an impact on reducing demand. We've seen a 30% reduction in some practices on the attendance levels of the people who attend most frequently, along with a fall in A&E admissions. And we know that this makes lives better for people. People talk about it's saved their lives, it's improved their lives. They don't need to go to general practice. They're doing things, they're taking a step to the left. They're doing things to improve their well-being. We also know it increases collaboration between staff, and that's something that we want to see happen as we go forward. And this work truly leads to a change in culture of general practice. It changes the identity of general practice. And what we see is that general practice actually becomes part of the community. It's no longer doing things for the community or even just with the community. People are working together as part of extended collaborative practice teams that are just an integral part of the place and of the community itself. So I will end with a question and an offer. The question I'd like to leave you with is, so what's next for you? What's your next step in thinking about how you're going to create a strong, sustainable social prescribing service that puts communities at the centre? It's a question that we continually grapple with. So I'm very happy to talk it through, have conversations with people. So do contact us. You can find us at our website. I'm happy to pick up any questions at the end, and look forward to having conversations. So on that note, I will hand you back to Siân and Jane and the other presentations this morning. Thank you.
Thank you, Alison. I've noticed that there's been some questions in the chat about whether the slides will be available later. I'm sure they will be. All conference slides, I'm sure, will be accessible to anyone that has registered for this conference. We will make sure they are, because I know it is quite difficult to absorb everything at the pace that people are going at in order to get through their presentation. Please do post any questions in the chat, or if you want to make connections, then please put something in the chat about that. Okay, moving on. We're now going to move on to Jenny Hartnoll, who is from Frome Medical Centre and is going to talk about Health Connections Mendip.
Hello, thank you for that introduction. My name's Jenny Hartnoll from Health Connections Mendip. So our service, like so many others, have one-to-one and group workers. Some people call them social prescribers, link workers. We don't call them that. We call our team health connectors. And our health connectors can work one-to-one and in groups on community development, on what matters to you type conversations. And as also as part of our service, we have a website directory which is there available for anyone in the community to access that information about the amazing support that's out there. From the very beginning of our service, we also had really important part of our service was our community connectors. So community connectors are members of the community who signpost friends, family, colleagues and neighbours to support in their own community. So it's like they're the voice of all those groups, all those amazing services out there. They learn about that information about those support groups and services themselves, and then they pass on that information. It's a 1-hour training. Anyone and everyone can be a connector. It's not about being a volunteer, but just about knowing that information and passing it on. And it's about people saying, I know what's out there, rather than if only I'd known that. So we've trained policemen, taxi drivers, hairdressers, sixth form students, doctors, cafe staff, grandparents, parents, homeless people, housebound people, job centre staff. And we've trained over 1,600 people. And we asked them in the first year how many people on average they signposted, and it was about 20 people a year. So that's 32,000 signposting conversations happening out there in the community every year, and that number of community connectors is growing each week. So that's how it started. It started with our community connectors. During COVID, people said they wanted to feel more connected online or get online. So we trained up our digital community connectors, and we've got over 60 digital community connectors who learnt that information themselves and then passing it on to others in their community. We also had people who said they really can benefit from things that they've done like Couch to 5K or health walks, and they said they wanted to train up to pass that information on to other people. So we developed our Healthy Lifestyles Connectors. We also had people who said they wanted to feel more confident about thinking about planning ahead for if they become less well, and also to have those conversations with people around them. So we've developed our Planning Ahead Connector training. We also noticed during COVID that people found it far more difficult to access hearing aid cleaning and retubing. So we developed an online hearing support connector training. We also heard that people wanted to find out information about keeping their homes warm. So we've trained up warm home connectors now who learn that information themselves and pass it on to others. We're just developing now our green community connectors, who are going to be people who learn about how to reduce your carbon footprint and how being healthy yourself is not only good for you, but also good for the planet. So these are really, really simple training sessions, and it's all about the community learning things themselves and passing it on to other people. A fantastic way to get information out there, the power of word of mouth. We also have projects that we've set up, really simple things based on what matters to the community. The community contacted us and said, we don't have groups to go to anymore because we're not allowed to meet inside. Can you help us create something outside? So we created our talking benches. So government legislation permitting, we run our talking benches every week out there in the community. We have one of our team members who's there the same time, the same place each week, who's a sort of point of reference for people and someone for people to talk to out there in the community. We also had shops saying to us, how can we get involved? So we thought about it and we said, okay, there's this worldwide movement of pay it forward, where you buy something for yourself and then you put some money behind the counter and give it to the shop, and then they pass that forward, and the next person who comes into the shop gets something for free. So we've got local bookshops that do that, cafes, and that's a great way of shops feeling like they're part of this movement, a part of being connected and being kind and sharing with their community. We also had people who said to us, but I feel I can't keep connected to people as well when I have my mask on, and someone suggested that they wanted to walk around town with a name badge on, so we thought, why not? So we trialled that with 20 people, and it was amazing, just that trial project, and we're going to get it going when we come out of lockdown. But people said it really helped, and we even had people on Instagram posting badges that they'd made for themselves. We also had people saying to us what matters to them wasn't about digital connection or us calling them up on the telephone or being connected to groups or anything. It was about receiving a postcard. So we, one of our team created a lovely postcard. We did a call out for volunteers, and those postcards are being sent out to people in the community regularly now. And we even had people in the community saying that they wanted to have those postcards just to give to their customers. And we heard recently that schools are using them, and the pupils who are going into schools are writing postcards, these postcards, to their friends who are homeschooling. We also saw an amazing booklet in Cumbria. We asked them if we could copy it, and they said yes. And we wanted to get that to every single household in our community. So we did a call out, and we had queues of volunteers saying, we want to do that. We want to deliver these booklets to people in our community. And those volunteers delivered it to 47,000 households in Mendip. Amazing. So these projects are really simple. It covers the whole population. They're replicable. Anyone and everyone can get involved. They're common sense. They belong to everyone. It helps create a feeling of a movement. They don't cost much. And it shows that social prescribing type services based on what matters to people and communities can be exciting, innovative, place-based, and they belong to everyone. So that core part of our work with the health connectors is really, really important. But our work spreads out and works alongside and with the community with all those other things that I've mentioned just now. And it really does help create a sense of a movement and that we're all in it together. Thank you very much. Over to the co-chair.
Right, if we could move on to Sarah now, Sarah Gorman, a colleague of mine from the Northeast who is based at Edberts House in Gateshead and is going to talk to us about social prescribing in communities. Thank you.
Thanks, Jane, for that kind introduction. So excited to be here today to share some thoughts around social prescribing, which has been one of our passions at Edberts House for many years. As Jane has already said, my name is Sarah Gorman, and I am the CEO of a community charity called Edberts House, which is based in Northeast in Gateshead, and also run a social prescribing scheme across the borough and work with NHS England as well. So it's a real pleasure to be here today. I want to talk about 4 areas that I think are important in social prescribing in communities at the moment. I want to focus on the first 2 though. Connection, control, creativity and culture I think are all important in the future. As I say, looking first at the first 2, connection and control. And connection, I think, is one of the vital parts of social prescribing. It's already begun. We've seen it in COVID, people connecting, social prescribers connecting with people, really tackling some of that isolation that's been experienced during COVID. But connection is really important for 2 reasons, partly because it's about how we identify ourselves. So when I talk about myself, I might say I am a mother, or I am a daughter, or I am a charity worker, all ways in which we connect with other people. And that's the way we define ourselves. And in many of our communities, those connection places have disappeared, and people have lost that sense of connection with one another. We talk to people in our communities who say, I'm nothing because my children have been taken away. I've never had a job. I've never had a way my partner has left me, never had a way to connect to others. And restoring that sense of connection is absolutely vital in the lives of people around us. And social prescribing can do that in a way where we can build relationships. At the moment, there are often lots of services that are to do with intervention or transaction, and that's important. Sometimes it's really important to intervene in people's lives and to do stuff to people. But actually, in relationship, we can start to build those connections without an agenda. And this is a very different way of relating. We're talking about what matters to you with a person, which is actually a very different way of supporting people and dealing with their issues. The other side of connection is that social prescribing gives us that opportunity to start to see connection within the system. This is one family that we worked with who had 63 different professionals involved in them. Very, very difficult for a family to be able to cope with that kind of complicated tangle of services around them. Social prescribing gives us an opportunity, because the social prescribers are a generalist, then actually they're able to support people around a number of issues and start to become the glue that connects the system together. In the past, our clinical health has been recorded by the GP and maintained on a system record. But over here, our non-clinical issues, the wider determinants of our health that impact on us, are disconnected and jumbled, and people found difficult actually to work with those. Now, actually, through social prescribing, we have that opportunity to link the wider determinants of health again into the GP record so that we can maintain one holistic health record at the GPs, which will start to make a real difference in people's lives. And the reason for that is connection builds control. Now, control is absolutely vital. That sense of control that we have an agency over our lives is one of the really important findings of Michael Marmot's work. So over the last 20, 30 years, Professor Michael Marmot has been researching the importance of control in terms of health and well-being. And actually allowing people to take a sense of control within their own issues is actually the one biggest factor that has been found to lead to longer life expectancy. So actually, if we really want to tackle health inequalities, then social prescribing is going to have an absolutely vital role to play in that, giving people that sense of control over those wider determinants issues and starting to help people have a sense of agency in their own lives. In terms of practical steps, and I think we need to understand that building connections and relationships takes time. We need to allow for that. We mustn't be pushing our social prescribers to be doing calls in 10 minutes or 15 minutes, but actually allowing them the time to build those relationships that are so important. We have to understand that this is not a linear pathway. And like all relationships, it will be a bit messy. We'll be working with people for a period of time. We're going to see them really progressing and possibly taking steps in what we would describe as backwards. And so in that sense, we need to be supporting people in a more complex way. And finally, giving control wherever we can. So in our conversations, what matters to you? In our recruitment, how can we get people with lived experience to come and help us with that? In our employment, ensuring that VCS organisations and community organisations are at the heart of that. And also gathering patient feedback wherever we can. Thank you so much. I'll hand back to Jane now.
Thank you, Sarah. That was great. Thank you. I also did notice that Jenny posted at 12:30 some links to some documents and website, Jenny Hartnoll, which may be of interest to people if they want to cut and paste that, if they were again struggling to hear the presentation. Okay, moving on to our final presentation. This is from Hannah McDonald, who is from 1 Northern Devon and Ilfracombe, and she's going to be talking about the evolution of social prescribing within our communities. Thank you.
Good morning, my name is Hannah McDonald and I'm the Community Partnership Development Manager for 1 Northern Devon. Before I start today, I just wanted to say a big thank you to the Chair and the organisers for allowing us to take part in this session today and speak to you all. Today I'm going to be talking about the evolution of social prescribing within our communities and the journey that has got us here so far. So just a little bit about us here in Northern Devon. Who are we? We are a partnership of public services, businesses, voluntary and community groups who work together to improve the quality of life for those living in Northern Devon. We exist to tackle health and social inequalities and to work as one system to improve quality of life for those in Northern Devon. We believe that the people that best understand communities are the people that live and work in them. Here at 1 Northern Devon, we have enabled the development of 6 One communities over the last few years. One communities are local partnerships to bring together residents and service providers to work on things that matter to their community, so local solutions for local issues. The first point on our social prescribing journey was in 1 Ilfracombe, which was our first One community that was developed back in 2013. The social prescribing service in 1 Ilfracombe is called our Community Connector service, and it has been running for about 6 years now. It was originally focused around older people and social isolation, but has now evolved to meet the needs of the whole community. It is around non-medical advice and support, and most referrals are now from self-referrals and GPs. The service is now primary care network funded, but over the years has been funded by adult health and social care and the fire service. Shortly after starting our social prescribing service, we realised...
Can I ask everyone to go on mute, please?
For a community development role, so a role that builds resilience, understands the importance of communities, and that can work very...
Oh dear, we've lost sound.
Siân, if you just press unmute, mute and unmute, or Jane, whoever's playing it.
Siân, I think.
Somebody obviously, when they mute all, they mute everybody, including me. So here we go. I'm going to press play again.
Tackles issues together, and steps out of its silos, develops projects alongside the community. So actually we are working as one. We have a large number of examples of how this model of community development, social prescribing and One communities is working very effectively alongside each other. A good example of this is our Men's Sheds project in Ilfracombe, which our community developer worked alongside members of the local community to be able to develop a men's sheds in Ilfracombe, and this was on evidence and feedback provided by our local social prescriber for a large number of men who were slightly older and wanted to get out a bit more, be a little bit more sociable. The Men's Shed has been hugely successful and has been going for a couple of years now, and even evolved into a virtual platform during the pandemic. The importance and value of social prescribing in Northern Devon has been realised by many people, but there are issues around capacity within our social prescribing teams. Some of our primary care networks have up to 50,000 people covering a very large geographical area, but only one social prescriber within their team. This, of course, is a huge capacity issue and puts an enormous amount of pressure on each of the social prescribers. Here at 1 Northern Devon, we are trialling the flow approach, which is looking at how we can embed some of the elements of social prescribing, such as person-centred support, holistic support, actually into everybody's roles instead of just one social prescriber. So what is the flow approach? The flow approach is an alternative to traditional social prescribing, where Practitioners have what matters to me conversations with the individuals they are working with and are supported to pull in support to flow around that person instead of referring them on to someone else. Here at One Northern Devon, we have developed a flow toolkit to enable practitioners to be able to have the confidence to have these conversations with people. It means that the individuals are only having to tell their story once. They are not referred off to other professionals or places, and support is pulled in to be wrapped around them. This has worked very successfully so far. We've trialled it with a number of different organisations and are currently trialling it with 3 GPs in our local primary care network. Thank you very much for listening today. Big thank you to all the team at One Northern Devon and all of our One communities for all of the amazing work that they do. For further information, please visit our website, which is www.onenortherndevon.org.uk, or email myself, hannah.mcdonald@northdevon.gov.uk. Thanks very much.
Okay, thank you, Hannah. That's great. Again, another quiet session. I have asked if the links to the Vimeos can be reposted in the chat because it's really difficult to follow the stream, so that people can actually listen to them later. I think we're going to try and manage this question and answer session, but it's quite difficult to pick up the questions from the chat. I don't know if it might be better for people to raise their hands to ask questions. What do you think, Siân?
Yeah, we can go with raising hands to begin with. We might have quite a few hands to go through, but luckily they come up in sort of chronological order. So whoever gets their hand up first will get asked first.
Siân and Jane, I've got something that's come up from the chat, if we want to start with this maybe.
Fabulous. Yeah, do please, Dan. That'd be fantastic.
Which is sort of, I think I'm compositing a few comments really, but do we want to have a situation where, you know, we have kind of one job title so that everybody knows who that person is, i.e. sort of social prescribing link worker? Or I think picking up on the last presentation really, do we want to sort of spread the model a bit and so that lots of people are doing social prescribing and this sort of flow model? And I think that'd be an interesting kind of conversation to have with some of the presenters.
Okay, fantastic question there. So thanks, Dan, and very interesting. I'm going to go to Sarah first for any comments on that around the role description and modelling locally. What are your thoughts?
We have stuck mainly with the name of social prescribing link worker for the professionals, if you like, who are doing that role. I guess I'm probably not too hung up about the language really, because primarily we want to get help to the people who need it in whatever way. So it's not I don't think we want to be precious about this stuff. The people that we can get on board, because the need is out there. The more people we can get on board in a voluntary capacity, supporting that agenda, training people up. There's been some fantastic examples in these presentations of really broadening out the scope of helping our communities really to be empowered and to take control. I think that's really exciting.
Super, thanks for that, Sarah. And Jenny Hartnoll, do you have any reflections on that?
Hi, can you hear me?
Yep, we can hear you.
I think there's a lot of discussion around job titles and the term social prescribing, and I think different things are useful to different people, and there's never going to be a one size fits all. And yes, we all have across the country, across the world, developed different names for the roles, and so it has got a bit messy. So we call our community connectors just active members in the community, whereas there are other people who have got community connectors that are paid roles. So it does create a bit of confusion, but that's kind of where we are, and that's how communities work, that we don't all necessarily agree to a job title. So yeah, it is complicated. I don't know whether there's really a solution to it now, because we've kind of got so far along the line, haven't we?
That's fabulous. Thank you for your reflections, Jenny. I see that we've got a couple of questions in the chat box. So I'm going to come to Sarah Payne, who had her hand up first. Sarah, what's your question for the panel, please?
It was just around hearing the use of sort of an online database type thing to for link workers to use to referring to, and I was just wondering with the last talk that I was just kind of getting up my notes then. Sorry, from Hannah, and it was just kind of wondering about that idea of we're recognizing things are moving very quickly to the point where sometimes we're trying to catch up with each other and noticing really good work. So I'm sort of interested in kind of how Elemental has really created a really good sort of database type thing that could be used, and if we are comparing, you know, the question is are we looking at models of practice that have already been going on and making comparison, and then is there a way of having a joined up place when if we do create another role, we can sort of add to that list and know and be able to share and communicate, because I think it gets confusing because it's so different. So apologies, probably more than one question there.
We'll stick to the one, Sarah, as we've got such a large group. So we'll come to Hannah, but just to let people know that there are other organisations available around in addition to Elemental. There's lots of growth in this area of tech supporting delivery of social prescribing. There's some really interesting growth around this across the country. So Hannah, your reflections on that from Sarah, please.
Hi Sarah, thank you. Yeah, so it's really difficult. So the way that we work here in Northern Devon with sort of different platforms, I guess, we sort of very much go for a place-based system. So when we're sort of talking about the use of platforms of databases and things like that, we're very much within sort of the local area and things. My background isn't medical. I'm not based within a GP practice. I'm actually local authority based. So I sort of come at things from a slightly different area. And when we started social prescribing, things like Elemental and things just weren't available to us. So we're on a bit of a sharp learning curve at the moment to sort of understand how that works with sort of GP practices and coming from that side. Our Community Connected Social Prescribing service very much started within the community and was, as I said in my presentation, was funded by a number of different organisations, including very, very random ones such as the fire service and people that really saw a real benefit to this. And actually the sort of the health side came later. It was much more sort of community-based adult social care came from that. And actually, interestingly, it started within a local town council in Ilfracombe. So we haven't come from the health arena, we've come from completely the opposite arena, but I think that's one of the really good strengths of what we're doing. So I'm not sure whether I've answered your question properly, Sarah, but I'm happy to talk afterwards if you wanted.
Fantastic,
thank you, Hannah.
And just wondering, Alison, if you've got any reflections. I know that you're working in GP practices, but are very much around focus on community. Have you come across people using tech in this way, Alison?
I'm not quite sure about your question, Siân. Can you say something more about the tech part? Using tech for what?
Sarah, in one sentence, give your question to Alison, please.
Sorry, I didn't see the question.
It's okay. It's how tech has evolved, and are we making comparisons to that evolving tech that supports social prescribing? Thank you.
So I'm not sure that I'm the best one to answer this particular question. I think that certainly the work that we're doing with Practice Health Champions has been about bringing people and human connection and human connectedness. We are using the tech to complement what happens in terms of those human connections, but we're really looking for face-to-face connections with people. We know that that's the stuff that makes the difference. The other stuff supports. The technical element from our point of view in terms of collaborative practice is actually using the data that we've got in general practice. General practice has the most robust source of data on community need, and what we're trying to do is marry up that need with people in communities. But I think in terms of the many champion bits of work that happen with practices, they would use tech, but it's not the principal starting point. The starting point would be human face-to-face connection or online or telephone connection.
And Alison, that is why you were the perfect person to answer and give a reflection. So I think the lesson there is this is about people, and the tech should only ever be the supporting mechanism around it. It shouldn't become our reason for being. So thank you for that really, really important reflection. So coming on to another question, Dragana, I can see here you have a question. Would you like to pose your question to the panel? You're on mute.
Turned on the camera but didn't microphone. Sorry, thank you. I very much like the client journey graph presented by Catherine and Dan from Bromley by Centre. And I just want to have to ask how are participants and the link workers finding the number of the data that you have to collect and information? Are they finding it difficult to provide all the information? How is the collection going?
That's a brilliant question. Thank you so much for that. So over to Catherine and Dan to answer that question. Who wants to take the first element of that response? Is Catherine here?
I can do it if you'd like. So I think the main answer to that is that it's a co-produced outcomes framework and methodology. So the community and the practitioners have been involved in both of those parts, in developing both of those things. So it is a research, it involves researchers, of course, in developing it, but as it's co-produced, us as researchers, we don't own it. The practitioners own it, and we're facilitating the methodology. And in terms of capturing the data, the challenge has been because we've developed a methodology that enables routine outcome measurement. We've embedded the system of data capture into existing systems within the practitioner client contact, and that seems to be working. But that was really, really crucial because you know better than me about how much time a practitioner has, how much time a client has, how much resource we've got to work with, and having to also remember the reason why we're capturing this information. Ultimately, it's to be able to work out what's working, what's not working, to refine service delivery, and also to bring the client front and centre. You know, we are answerable to them. So this is an opportunity to be able to channel that voice, but also have evidence to go back to the clients to say, well, this is how this is working. Does that help to answer your question?
Dragon, we're on mute.
Again, I'm mute, sorry.
Sorry.
Yes, thank you. Yes, absolutely, it does answer. Wonderful.
Fabulous. That's great. Thank you so much, Catherine, and for your question as well, Dragoner. So on to the next question, Caroline Biggs.
So I just had a question to the panel in terms of kind of job role and job title. So I work as a health and wellbeing coach in East Devon, and a lot of my time seems to be spent kind of explaining or defining our role, both to patients and also kind of other healthcare professionals. I was just wondering whether it would be like something for the future where there were sort of more redefined clear roles within social prescribing, so that in the same way as people recognise what a GP is and there's almost sort of assumptions made, whether that would, like going forward, be really helpful for social prescription. Because I know within Devon there's link workers, there's community connectors, we're health and wellbeing coaches, and I think a lot of time spent and kind of misplaced in defining who we are and what we do and where the parameters are. And I just wondered whether, if there was a more kind of top-down approach, whether that would be helpful or not.
Okay, I'm going to come over. Thank you for that question. Great question. I'm going to come over. I have my own views on this, but I'm going to come to Sarah. Sarah, would you like to give your perspective on that?
Yeah, I mean, I think I have kind of two perspectives really, which are probably slightly conflicting, which might not really help you. And I appreciate the question and the confusion that it causes. I think as time goes by, then those roles I guess will become more distinct. So I know there's distinct training packages that are being developed for each of the different roles, and I think at the moment there is a kind of, we're on a bit of a journey with that in terms of how they will all fit together. Underneath that though, I do think there is a lot of overlap personally. And with my Edberts House hat on, then in Gateshead, as I mentioned before, we have chosen just to have social prescribing link workers who will have the training to be health and wellbeing coaches, so that they can use that interviewing and those motivational interviewing techniques within their role. But rather, because for us, I think relationship is very important. So keeping people working with one person shoulder to shoulder through their stuff, rather than lots of handoffs to different people, we felt personally was a better way to work. So I think keeping relationships in the heart and having that one person, somebody who talked earlier about that idea of people services being on the pull rather than us referring out. And certainly in our experience, that is how we work, and we've found that helpful. So it's probably a little bit of a confusing answer, but yes, that's how I would approach that at the moment.
Excellent. Thank you so much for that, Sarah. I can see that Alison, you've got your hand up. Is that in response to this question? Yeah, do you want to?
Yeah, it is. Yeah, so one of the things that struck me around this idea of overlap and duplication, I find it really interesting. I understand why it's seen to be an issue, but when I think about what our data tells us about the level of need, you know, we don't have one profession called a doctor. We have a whole lot of different kinds of doctors, people who do different things. And I think that in this work, the level of need is so great. The level of need post-COVID is going to be even greater. So I think there's plenty of room out there. And I think we should just hold hands, you know, not sort of argue the toss about what we're called. I think we say, this is who we are, this is what we do. And I really love it when people don't know what we do, because it's an excuse to have a meaningful conversation. So I think it's not a bad thing. I think it's a really good thing that we've got all of these folks doing different things in different places.
Super. Thank you so much, Alison. And Hannah, your hand's up. Is that in response to this as well?
Yeah, I was just going to very quickly say, I think it's sort of very much a reflection of actually the different names. It sort of fits what different places need. So as I said before, we work in a very place-based way. So actually some of it might just be that's what you need in your area. But the other sort of reflection for me, and the reason that we're looking at this flow approach around sort of pulling services in, is if we find this confusing, how confusing and complex is it for people that are trying to use these services as well? So the whole idea around the flow approach is that actually we're streamlining it so that whoever the practitioner is, whether they're a GP, whether they're a housing officer, whether they're somebody working in the voluntary sector, can actually sort of create a team around this person and wrap the support around them, instead of having to bounce them off into a system that we find confusing and they will find an absolute nightmare. So thank you.
That is wonderful. Thank you so much for that response. Thanks, Hannah, Alison and Sarah for that. I can see that we're very quickly running out of time. I just want to share the Mentimeter now. The number is 3604401. You can see from the screen that first question now is back on track. I'm just going to pull it up onto my screens. And there are just two questions. The first is to what degree you feel your local social prescribing scheme is asset-based and community-focused, from 0 being not asset-based to 5 highly asset-based. And then you can see there we're on the way, aren't we? Which is fantastic. And seeing our speakers here today, thank you to Jenny, Sarah, Hannah, Alison, Catherine and Dan for all of their presentations. There's some exemplary examples of good practice across the country. Do connect with them. This is how we learn from each other across the country. You have a national social prescribing platform, you've got a national network. Everybody is very happy within this realm because of our passion and dedication to really connect with what's going on. And then the next question on there is, do let us know what you think is needed to facilitate that asset-based community-focused social prescribing. So let us know what's still missing. So you can go to these questions through Menti after this session over the lunch break. Do go into the chat rooms now. on the break. Do spend some time getting to know people. This is about connecting. Social prescribing is all about connecting. There are some fabulous people, some fabulous schemes. You know, make it your mission over lunch break to talk to at least one person that you don't know already, that, you know, sparks your interest. Thank you very, very much to Jane Hartley for chairing the beginning of that session, and to Dan Hopewell for helping us manage behind the scenes with the chat and the questions, and helping to sort Menti. Thank you once again to all of the speakers for a fabulous session around community matters. Take care, everybody, and enjoy the rest of the conference.